Hello, my name is Dr. Stan Althof, and I'm the Executive Director for the Center for Marital and Sexual Health of South Florida and an Emeritus Professor at Case Western Reserve University School of Medicine. I'm going to be speaking with you about Bremelanotide, a novel treatment for female hypoactive sexual desire disorder. Specifically, I'm going to present the results from the Phase 3 clinical trials of Bremelanotide. These are my disclosures. Let's begin by looking at the DSM-IV definitions for female sexual dysfunction. The reason we're using DSM-IV rather than DSM-V is that when this drug was first submitted to the FDA, DSM-V was not published, and the agreement was to use hypoactive sexual desire disorder and the definition found in DSM-IV-TR. As you can see, and I will use HSDD as the abbreviation for hypoactive sexual desire disorder, HSDD was defined as a deficiency or absence of sexual fantasies and desire for sexual activity. What's very important, and you'll find this on the bottom of the slide in red, is that all the female sexual dysfunctions required that the woman experienced marked distress or interpersonal difficulty. Also, the sexual dysfunction could not be better accounted for by another Axis 1 disorder like depression, and is not exclusively due to the physiological effects of a substance or general medical condition. Hypoactive sexual desire disorder was merged with female sexual arousal disorder in DSM-V, and the names for the sexual pain disorders were also changed in DSM-V. Now, HSDD manifests itself in several ways. First is a lack of motivation for sexual activity by reduced or absent spontaneous desire. That is, the woman doesn't feel a sense of sexuality within herself as seen by sexual thoughts or fantasies, and or she may not have responsive desire. That is, she may not be responding to erotic cues or stimulation, or she may have difficulty maintaining the desire through the sexual activity. Again, it has to be combined with clinically significant personal distress. There are two subtypes of female sexual dysfunction. They're found in both DSM-IV and DSM-V. The first subtypes are lifelong versus acquired. Lifelong refers to when the sexual dysfunction has been present since the onset of sexual functioning, and acquired means that the sexual dysfunction develops after a period of normal functioning. The other subtype is generalized versus situational. Generalized refers to sexual dysfunction is not limited to certain types of stimulation, situations, or partners, meaning it occurs all the time, versus situational, where the sexual dysfunction is limited to certain types of sexual stimulation, situations, or partners. Bremelanotide is for acquired and generalized female sexual dysfunction, specifically HSDD. These are the medical treatments for HSDD. 2 years ago, flibanserin, known as Addy, was approved by the FDA for generalized and acquired treatment of HSDD in pre-menopausal women. Other forms of treatment are off-label, such as the use of estrogen or testosterone, or a combination of estrogen and testosterone. Also, off-label use of bupropion, known as Wellbutrin. What concerns many of us clinicians are that women who are very desperate will purchase unregulated suspiciously marketed products with no proven safety or efficacy from the Internet. This slide shows the psychological treatments for HSDD. Let's begin with sex therapy. Sex therapy is generally a short-term intervention focused on the person's complaint, sexual complaint. Generally, we do cognitive behavioral interventions and also add in behavioral interventions such as sensate focus. We may also treat the relationship in relationship therapy, where we focus on power, control, trust, and communication issues. And when patients complain about a boring sexual life, we may look at their sexual repertoire, which is repetitive, dull, and lacking any inspiration, and try to help them with that. Thirdly, Dr. Lori Brotto has introduced sex therapy field to mindfulness meditation, which helps the woman be in the present, sort of be here now. I want to make a comment about combining medication with psychological interventions. In men, combining the ED drugs like Viagra, Levitra, Cialis with focused psychological interventions has been shown to be more efficacious than either the drugs alone or psychological intervention alone. In the future, this is something we should think about with female sexual dysfunctions, combining the approved medications with some form of psychological intervention. I want to tell you a bit about bremelanotide. First, bremelanotide was originally developed by Paladin Pharmaceuticals for the treatment of female sexual dysfunction and erectile dysfunction. It is a novel cyclic 7-amino acid melanocortin receptor agonist with high affinity for the type 4 receptor. Bremelanotide acts in the brain, and if you would really like an understandable, sophisticated, and well-done presentation on this, I recommend that you listen to Dr. Jim Faust's presentation that's also part of the Her Desire presentation. Bremelanotide is a CNS active drug. It's not a sex hormone, and it does not require the presence of sex steroids for activity. It was originally developed in an intranasal formulation. Now, however, they use a subcutaneous administration because it provides an improved tolerability profile. Some regulatory information that you may want to know. In February of last year, Amig Pharmaceuticals and Paladin signed a North American license agreement for bremelanotide. An NDA, or new drug application, was submitted to the FDA in March of 2018 and was recently accepted for review. Completion of the FDA's review is expected before March of 2019. This slide shows the methodology for the Phase 3 trial. Let me begin by saying that the FDA requires that there be 2 identical trials when drugs are submitted to them for review. We're going to call these 301 and 302. They're the same exact methodology, but with different cohorts of women. The methodology begins with a screening month, where women come in, they receive no treatment, but they keep track of their sexual activities for the first month. Then they are screened to see whether they can still be in the study, and there's a 1-month at-home placebo self-dosing month. So this is a single blind. The clinicians know that the woman is receiving placebo, the woman doesn't. The reason we do this 1-month placebo is because we know the great effect that placebo has on female sexual dysfunction. There's generally a very strong response to placebo. And what we want to do is get the women to have the response before they begin the actual study drug versus placebo phase. So at the end of the placebo phase, That becomes the woman's baseline. Next, there's the at-home study drug self-dosing, where the woman is randomized to placebo or 1.75 milligrams of Bremelanotide for 24 weeks. This is done at home. And finally, after the 24-week randomized treatment phase, the woman is asked if she'd like to volunteer for a 1-year open-label extension where she will receive 1.75 milligrams of Bremelanotide. This is a way to look at long-term safety in a larger population of women. This is a picture of the auto-injector. Women use this auto-injector to inject themselves in the anterior thigh or abdomen 45 minutes prior to sexual activity. What I'd like to do now is go through with you the patient-reported outcomes that were used to assess female sexual dysfunction in this trial. I'm going to start with the upper left and go clockwise. Let's begin with the Female Sexual Function Index, or FSFI. It's composed of 19 items, and it is a very validated measure. It's considered the gold standard for female sexual dysfunction assessment. Items are responded to on a Likert-type scale, and there are 6 domains and a total score. The recall period is the previous 4 weeks, and higher scores indicate a greater or better level of sexual function. Moving to the right, the Female Sexual Distress Scale Revised is a 15-item validated measure to assess sexually related distress. You may recall that the definition of HSDD requires that the woman be clinically distressed. The items are also responded to on a Likert scale, and item 13 specifically asks about distress related to low sexual desires. Higher scores on this measure indicate more distress. Moving to the bottom right, the Women's Inventory of Treatment Satisfaction, or the WITS-9, is composed of 9 items that assess satisfaction with the treatment. Items are also responded to on a Likert scale. Higher scores indicate a higher level of satisfaction. Moving over to the bottom left, the Female Sexual Encounter Profile Revised, or the FSFI. It's a 10-item diary measure. It's completed within 24 hours after sexual activity, whether or not the woman has used drug or placebo. One item assesses satisfaction with the sexual encounter, and this item becomes the satisfying sexual event item. This is a controversial item because it's not in the definition of HSDD, and many people, many clinicians, think that it's distal to or away from the woman's desire. Specifically, some women with high desire may report few satisfying sexual events, and other women with no desire may report good sexual events. We also use the general assessment questions, and the point of the general assessment questions was to see whether or not a woman would define herself as a responder. If you look at the bottom of the slide, the third GAQ question asks, compared to the start of the study, prior to taking the study drug, to what degree do you think you benefited from taking the study drug? Women responded on a 7-point scale from very much worse to very much better, and we'll discuss this toward the end of the presentation. This slide shows you the primary and secondary endpoints of the Phase 3 clinical trials of Bremelanotide. The 2 primary co-endpoints were the change from baseline to the end of study for the FSFI desire domain, and item 13 from the FSDS-R. The secondary endpoints were the change from baseline to the end of the study on the FSFI total score and the arousal, orgasm, and satisfaction domains. The number of SSEs, the FSDS, or Female Sexual Distress Scale total score, and the question on arousal, which was question 12, and the Women's Index of Treatment Satisfaction, the WITS-9 total score. The entry criterion for the study were healthy, premenopausal, non-pregnant women older than 18 years of age and currently in a stable, defined as relationship. Let's stop there for a second. And currently in a stable relationship with a duration of greater than 6 months. They had to be diagnosed with HSDD for at least 6 months and had experienced normal sexual function in the past for more than 2 years. The women had to be willing to engage in sexual activities once a month or more during the course of the study, and they were also given other questionnaires at screening, such as the Patient Health Questionnaire 9, or the PHQ-9, which was to examine their degree of depression. There was a cutoff score. If they scored that, they could not be in the study. They had to take the FSFI and look at the total score being less than 26 and the desire domain being less than 5. And they took the Female Sexual Distress Scale, and the total score needed to be more than 18. There were also requirements for the number of satisfying sexual events depending on the frequency of sexual activity. This slide shows you the baseline characteristics of the women in the study. You'll see here that we have study 301 on the left and study 302 on the right. The mean age of the women was between 38 and 39 years. This was a predominantly white population. The length of time in the relationships was approximately 12 years, and the women had approximately a 4-year duration of HSDD. I want to show you the study disposition of patients. Again, on the left, you're going to see study 301, on the right, 302, and to remind you, these are the exact same study. 301 enrolled 653 patients, of which 326 received placebo and 327 received bremelanotide, which is abbreviated BMT. 302, you can see the numbers, 614 were enrolled, 306 received placebo, and 308 received bremelanotide. What we look at next is the boxes in the middle, or the discontinuations. And you can see there's withdrew consent, adverse event, noncompliance, and so on. For the 301 study, the one on the left, you can see that there were discontinuations of 60 women due to adverse events, and 33 women withdrew consent, and 23 women, all these who received bremelanotide, were lost to follow-up. You see similar numbers on study 302, where 38 women who received bremelanotide withdrew consent, 35 who got placebo withdrew consent. Adverse events, 55 women on bremelanotide discontinued versus 9 who received placebo, discontinued because of adverse events. On the bottom, you see we have a total of 274 women who received placebo and 190 women who received bremelanotide completed 301, and 219 women who received placebo and 173 who received bremelanotide completed study 302. I want to begin by showing you some of the results to this study. This is the first co-primary endpoint, the improvement in desire as assessed by the FSFI desire domain. 301 appears on the left, 302 appears on the right. The dark blue columns are the women who received bremelanotide. The light blue are the placebo women. Compared with placebo, women taking bremelanotide had significantly increased scores on the desire domain of the FSFI at 6 months. And you can see that this occurs at a very high level of significance, 0.001. So the sexual desire, sexual function component desire, improved on bremelanotide greater than it did on placebo. Next, we're looking at a reduction in distress. The reason the columns go down is because we want to look at the reduction. Again, 301 appears on the left, 302 on the right. Light blue is placebo, dark blue is the bremelanotide population. And you can see that compared with placebo, women using bremelanotide had a significant reduction in distress as measured by item 13 on the FSDS. And this was also at a very high level of statistical significance, 0.001. So both co-primary endpoints, the FSFI desire domain and item 13, these endpoints were achieved. Now I'm going to show you the secondary endpoints. We'll begin with the FSFI, both the total scores and the satisfaction, orgasm, lubrication, and arousal domains. The shaded maroon and the crosshatch maroon are the bremelanotide women, and the shaded gray and the crosshatch gray are the placebo group. You can see that the total score, satisfaction domain, orgasm domain, lubrication domain, and arousal domain all show that the bremelanotide group did significantly better than the placebo group at the 0.01 level of significance. So all of these secondary endpoints were achieved. These two graphs show you the arousal distress question from the FSDS and the total distress score from the FSDS. Again, 301 is on the left, 302 is on the right, and the shaded maroon and the crosshatch maroon are the bremelanotide women. The shaded gray and the crosshatch gray are the placebo women. You can see that distress is significantly reduced in the bremelanotide versus the placebo group, again at high levels of significance. The third secondary endpoint is the total change in the WITS-9 score. Here you can see that, again, the bremelanotide group were significantly more satisfied with treatment than the placebo group. The fourth secondary endpoint, satisfying sexual events, failed to achieve differentiation or significance between the placebo and the bremelanotide group. So summing up the secondary endpoints, 3 out of 4 endpoints were achieved. The fourth, the satisfying sexual events, did not meet significance and was not achieved. Now I'd like to talk about the responder analysis. As I mentioned before, the women are asked at the end of the study, compared with the start of the study, prior to taking the study drug, to what degree do you think you benefited from taking the study drug? And they respond, as you can see on the left side of the scale, from very much worse to the right side of the scale, very much better. And then you look at the right side of the slide. This is the percent of responders. These are self-defined responders. Women who said they did better, much better, or very much better. 5, 6, or 7 were deemed responders, and people from 1 to 4, very much worse, and no change, were non-responders. And you can see that women taking bremelanotide reported significantly more benefit from treatment compared to those taking placebo. That is 58% in 301 and 58% in 302 versus approximately 36% of women who received placebo. When we take the responder analysis and look at then the patient-reported outcomes, the FSFI or the FSDS or satisfying sexual events, you notice that those people who identified themselves as responders did significantly better on the FSFI desire domain, the FSDS, question 13, and even the satisfying sexual events. And you can see this in both studies, 301 and 302. Women taking bremelanotide reported significantly more benefit from treatment compared with those taking placebo based on the general assessment question. In any study, you want to look at the adverse events. The most frequent adverse events were nausea, flushing, and headache. If you look at the bremelanotide study 301, you can see that 42.6% of women reported nausea at some point during the study. 37% of the 302 group taking bremelanotide also reported nausea. Flushing, 26.2% of the 301 group, and 14.2% of the 302 group reported flushing at some point during the study, and headache was reported by 9.9% and 12.2% of women receiving bremelanotide. So in conclusion, the Phase 3 bremelanotide trials reflect the efficacy, safety, and satisfaction with the medication. Both primary endpoints were achieved. Again, the FSFI desire domain and the FSDS question 13. And 3 out of the 4 secondary endpoints were also achieved. If approved by the FDA, bremelanotide offers women and clinicians an alternative, non-hormonal, on-demand medication for the treatment of hypoactive sexual desire disorder. And we know that hypoactive sexual desire disorder remains a distressing condition for many women and their partners. Thank you for taking the time to listen to this presentation.